Distal biceps ruptures, a ticking time bomb by Val Jones. Working in a regional trauma centre, we're used to seeing lots of soft tissue injuries on a regular basis. But the one that was considered more unusual when I first started working at the shoulder and elbow unit in Sheffield over 20 years ago was the acute distal biceps rupture. Previous literature both on UK and US populations describe it as a rare injury, with an incidence of 1.2 to 2.6 per 100,000 person years. This equated to seeing and operating upon about 10 and 12 patients per annum from the Sheffield population of approximately 750,000 during the first few years of the millennium. However, in the last decade there has been an explosion, quite literally, in the number of patients attending our unit with distal biceps rupture. Our team now on average sees up to 40 cases per year, over a 300% increase over a 20-year period. These figures made me question what was driving this increase, and was this just a regional trend or something that other orthopaedic units were seeing? Also, what are the implications for an already struggling healthcare system to cope with an increased demand for surgery, imaging, resources and post-operative rehabilitation? Trawling through recent literature, there is very little written on the incidence of these injuries, apart from one study looking at Swedish and Finnish registries, which found a 6 to 7-fold increase in this type of injury and a 28-fold increase in distal biceps repair surgery. Staggering numbers with a huge implication for resource allocation, with figures that echoed our own experience in Sheffield. In the general population, full thickness tears are most encountered in active middle-aged men between 40 and 60 years of age. Often when questioned, these patients have had no warning signs before their tendon tear. The incidence in women is extremely low, and clinically I've only met one female with this injury in my 23-year tenure in Sheffield. An evaluation of distal biceps tendon ruptures in women sees them describe a more gradual onset of symptoms and a higher incidence of partial tears rather than full thickness ones. Other predisposing factors to injury may include an elevated body mass index, BMI, smoking and medication use. Elevated BMI, possibly secondary to greater muscle mass, would increase the load on the tendon and may predispose to rupture. Furthermore, obesity has been shown to decrease immune responses to acute tendon injury. Of patients with a distal biceps tendon rupture, 36 to 66% are reported to be obese, compared with the general UK population obesity rate, which is approximately 30%. The exact incidence of smoking in patients with distal biceps tendon ruptures is unknown, but it is widely accepted that smoking is a predisposing factor in tendon injuries. One study quotes a 7-fold increase in distal biceps ruptures in smokers compared with non-smokers. Smoking rates have increased in the adult population of those aged 45 and above, which is the peak age for these injuries to occur. A possible effect of smoking involves an increased zone of hypovascularity in the tendon between the proximal and distal blood supply. Patients often ask if vaping carries the same risk as cigarette smoking, but I have to be honest and tell patients that I just don't have that answer currently. Maybe the correlation between musculoskeletal injury risk and vaping will become more evident over time. The image and performance enhancement drug, IPED market, including anabolic steroids, has become increasingly accessible through online sellers, which has broadened their appeal to a wider market. Their usage has become semi-normalized and socially acceptable, coining the term gym and tonic. Weightlifters are the primary user group of IPEDs, with increase in usage seen in both males and females. Anabolic steroid use combined with exercise may lead to dysplasia of collagen fibrils, which can decrease the tensile strength of the tendon with an associated increase in muscle strength. Changes in tendons' crimp morphology have been shown to occur as well, which again may alter the tensile strength of the tendon. Less commonly, tendon rupture can also be linked with statin or fluoroquinolone antibiotic use. High-risk sports for distal bicep tendon ruptures are weightlifting, American football, judo and other contact sports, and usually occur when an eccentric force is applied to a flexed or supinated elbow, with most patients describing an audible pop followed by pain and weakness. Not all are sporting injuries though. In Sheffield, we've seen it in patients who've tried to stop their dog running off by hanging onto their collar or by trying to catch a wardrobe falling down the stairs. That was never going to work out well. After discussion with the surgical team, most medically well patients opt for an acute repair. An acute repair is deemed less risky for patients with less chance of post-operative complications. However, one note of caution is there is a lack of clinical consensus on the role of operative treatment. Support for surgery has largely been driven by biomechanical studies that report a reduction in supination and elbow flexion strength, as well as impaired endurance seen in injuries managed non-operatively. There is a lack of robust evidence comparing non-operative versus operative treatment. Public perception towards surgical treatment is often positive, although the evidence of its superiority over other treatments is lacking. When considering surgery, there is often a disregard for the associated risks, with individuals often taking a "it will never happen to me" stance. But distal biceps repairs carry a huge 25% complication rate, with 1 in 20 patients suffering a serious adverse event such as vascular or nerve injury, heterotopic ossification, or re-rupture. Given the real risks involved with surgery, what's driving the increase in this procedure? Firstly, the recognition of the injury and accuracy of diagnosis by healthcare professionals may have improved. Physical examination techniques such as the commonly used hook test, combined with a careful history, make swifter diagnosis more likely. Historically, patients with a delayed presentation were often advised against surgery, as delayed repairs are associated with higher complication rates. So faster diagnosis probably leads to an increase in surgical conversion rates. The availability of modern imaging technology such as MRI and ultrasound scans may have made confirming the diagnosis easier, and again will decrease any delay between injury and diagnosis, once again leading to an increased possibility of surgery. Other reasons may be that with increasing sporting participation and more active older populations, the incidence and age at presentation of this injury would be expected to rise. This group of patients may be more interested in full recovery, and therefore surgical options are more likely to be explored, as patients are unwilling to live with a lifelong strength deficit and cosmetic deformity often seen following conservative management. Recent advances in surgical techniques such as the use of button techniques allow for strong initial fixation, which allows early active mobilization. Music to most physios' ears. There is little consensus on the optimal post-op rehabilitation program, but our own in-house experience of immediate active post-op mobilization resulted in a faster return to function with less physiotherapy intervention compared to delayed mobilization. There was no increase in complication rates, such as re-rupture following accelerated mobilization. Loading above 10 kilograms is avoided for 3 months post-op because of the pull-out strain of the button devices used, but otherwise there is no other restrictions placed on our patients. In conclusion, distal biceps ruptures are becoming increasingly prevalent for a variety of reasons. Healthcare practitioners should remain vigilant in diagnosing the injury and swiftly refer on for urgent surgical opinion. Despite the lack of robust evidence, surgery in the medically well is considered the current optimal treatment approach, with early mobilization following surgery appearing to be beneficial both in terms of speed of recovery and use of physiotherapy resources.